Two, one. We are live now.
So, good evening all. On behalf of Rajasthan Orthopedic Surgeons Association, I welcome you all to the another series of masterclass in hand surgery from Rajasthan Orthopedic Surgeons Association. So, the today's topic is the fracture dislocation of PIP joints. It's a very common issue. We have galaxy of faculties, to the national renowned faculties, Dr. Parag Lad and Dr. Srinivasan, and the ROSA faculties. I also welcome our ROSA president, Dr. Kishore Raichandani, and Madam Purnima Patni, who is the president of Jaipur Hand Surgery Society. So, to formally inaugurate the today's proceedings, I would like to invite ROSA president, Dr. Kishore Raichandani. Over to you, sir.
Thank you, Rahul. Thank you very much. And it's because of Rahul's active participation and active involvement that ROSA has been able to do all these things which he has mentioned just before. And Amit is again another instrumental in getting the master classes every month and inviting such the great legends in the field. And I'm very happy to see both of you, and we welcome you. And I would like to start the proceedings. I would hand over to Amit to start the proceedings, please.
So, thank you, sir. So, today's moderator is Dr. Amit Vyas. I would request him to introduce the national faculty and the ROSA faculty first, and then start the proceedings.
Thank you, sir. Good evening to all. I am highly thankful to ROSA official to giving me this opportunity to conduct this master class on PIP fracture dislocation. As you all know that this is quite a significant problem generally encountered by orthopedic surgeons, and because of unawareness of the surgeon, it may be missed. So ROSA official asked me to conduct a webinar on PIP fracture dislocation, so we can learn from our master from the nation that how we can prevent these type of injury. So in this webinar, we will try to focus how not to miss these type of injury and what are the treatment considerations, what are treatment available for this problem. So for this, we have invited our guest faculty, Dr. Srinivasan Rajappa. Dr. Srinivasan Rajappa is he is the head of the department of hand surgery department at Sri Ramchandra Medical College, Chennai, and it's a prestigious institute of the India. He is a fellowship trained hand surgeon from various prestigious institutes like CMC Vellore and Ganga Hospital, and he has bright academic career, and with more than 20 publications, chapters in books, and he has presented in various conferences, national and international level. And one significant feather in his cap that now he is among the few institutes of the India who trains hand surgeon by doing MCS in hand surgery MCS hand surgery program in the India. So as then our second faculty is Dr. Parag Lad. Dr. Parag Lad, sir, he is also a fellowship trained hand surgeon from Ganga Hospital and then NUHS Singapore. Sir is senior consultant at Jupiter Hospital and Pinnacle Ortho Care Center. Sir has also numerous publications and presentation series at national and international level. Welcome, Dr. Srinivasan and Dr. Parag Lad. And with this, we have our own galaxy of star. Dr. Kishore Raichandani, sir. Sir is President ROSA and sir is Senior Professor at Jodhpur Medical College. And Dr. Rahul Katta, sir, he is Honorary Secretary ROSA and he is probably he don't know any, he doesn't need any introduction because he is quite active at national and international forums and sir owns his hospital at Jaipur, Katta Hospital, Jaipur. Then Dr. Jaswant Singh, sir. Sir is Vice President ROSA and sir also owns his hospital at Kota. Purnima Patni, madam is our teacher and mentor, as madam is retired professor and head from Orthopedic Department, SMS Medical College, Jaipur. Presently, madam is working at Surya Hospital, Jaipur. Dr. Rahul Garg, sir is also senior consultant at Jodhpur Medipulse Hospital. Sir is also active member of ROSA and joint secretary of ROSA at present. Dr. Sudhir Kumar Yadav, sir. Sir is senior professor at SMS Medical College, Department of Orthopedics. Welcome, sir.
Thank you.
And Dr. Vinit Arora is senior consultant at Jeevan Rekha Hospital and he is renowned hand surgeon at Jaipur. And Dr. Aviral Gupta, he is also well-renowned hand surgeon in Jaipur. He is working at SDMH Hospital, Jaipur. Dr. Raghavendra Vyas, he is our junior most fellow in the ROSA. But he is also trained from KMC Manipal, a prestigious institute who trains hand surgeon in India. So welcome, Raghavendra. So with this proceeding, I welcome you all. And first of all, I will invite Dr. Srinivasan Rajappa to deliver a lecture on PIP fracture dislocation. Then it will be followed by some interesting case discussion by Dr. Parag Lad, Dr. Vinit Arora, and by me. And we will discuss all the aspects of PIP fracture dislocation. So, Dr. Rajappa, please share your screen and start the proceedings.
Hi, good evening, all of you. Can you hear me?
Yes.
Yes.
Oh, great. Okay. Now I'm going to share my screen. Just give me a minute. Can you see my screen now? Can you see my screen now?
No, sir, we are
Yeah.
not.
Now?
Yes.
Now can you see?
No, boss.
Yes.
Can you see my screen now?
No.
Okay, just give me a minute. One second.
Sir, if you are doing it from mobile, then it won't be possible.
I'm doing it from an iPad. Is that okay?
Acha, iPad again. Yes. Now.
Now you can see, right?
Yeah.
Just a minute. Just give me a minute. Can you see now?
Yeah.
Yes.
Loud and clear.
Oh, great. Sorry for the initial hiccup. I am delighted to be a part of this presentation, and I'm grateful to Amit, Vyas, and the others in the organizing committee of this education program for having given me an opportunity to do this presentation. I first met Amit Vyas in Ganga Hospital when he had just about joined his FNB in hand and microsurgery. And I was there on a microsurgery fellowship for a couple of months. And the moment we met each other, we sort of hit common ground because we were too, at that time, young. Amit continues to be young, but I have grayed a little bit. We were two young orthopedic surgeons who were just unbelievably homesick. And although I was not very far away from Coimbatore, my hometown is Madras, and I was not very far away from there, we still gave each other a shoulder to cry on at times. So a friendship which has lasted that much. Thank you, Amit, for all the friendship and all the goodwill. And I'm also very honored to be in the presence of very senior professors. Amit used to tell me a lot about Professor Purnima Patti. I'm delighted to be here, madam. And we have heard a lot of stories about you, and it's wonderful to do this presentation. And as mentioned in the introduction, I think this continues to be the nemesis of the orthopedic and the hand surgeons or whoever is treating proximal interphalangeal joint injuries. This almost is at epidemic proportions, and as people play a lot of sport, more and more people are having these injuries, and more are not maybe seeking the appropriate treatment as it would be likely. So I work in the Department of Hand Surgery at Sri Ramchandra Institute of Higher Education and Research in Chennai. I head the department. I'm an orthopedic surgeon by training, and I have hand surgery fellowship from Vellore, Singapore, and then Ganga Hospital. Now, we look at the anatomy of the proximal interphalangeal joint. It's very similar to the knee joint. It's a bicondylar hinge, and it's got a range of motion about 120 degrees. 0 to 120 degrees is important. It's not 0 to 90 degrees. Because 120-degree range of motion is necessary for us to be able to touch the digitopalmar crease. And it is responsible for 85% of the finger movement, which is necessary for grip. And that's how it looks. The head of the proximal phalanx, which is trapezoidal in shape, it's got a groove in the middle, which got a reciprocal accommodation of a ridge at the base of the middle phalanx. Now, this anatomy is important to remember because this has a relevance to hemi-hamate arthroplasty, about which we'll be talking a bit later. It's got a palmar tilt of about 20 degrees. Now, this is actually called a hinge joint, but we realize that it's not a perfect hinge. The radii of curvature of both the head of the proximal phalanx as well as the base of the middle phalanx are completely different. And because of this, it almost functions like a knee joint, like how the distal femur and the proximal tibia function. It's got an instantaneous axis of rotation. And that makes it a bit challenging when you design processes and you're trying to put external fixators exactly in the so-called center of rotation. If you look at the condyles of the head of the proximal phalanx, they are not actually very flat out. The condyles on the radial side are more prominent on the radial side, and the ones on the ulnar side are more prominent on the ulnar side. Or in other words, the ulnar condyle of the little finger is likely to be more prominent distally than the radial condyle of the little finger, and vice versa for the index finger. Now, this is what makes the fingers converge to the scaphoid tubercle as the finger flexes. Now, this is important to understand because if you're treating fractures of the head of the proximal phalanx, now, even after we sometimes do an open reduction and we get a perfect reduction and then we image it in the X-ray, you could still see what is an illusionary step off. So in that situation, we should try not to undo the whole fixation and redo the whole thing and create a mess out there. Now, if you look at the ligamentous anatomy, it's so-called the box configuration, as it is called. It's got a volar plate on the palmar side, and it's got the collateral ligaments on either side. Now, the volar plate resists hyperextension forces, and the collateral ligaments provide mediolateral stability, very similar to what happens in the knee joint. Of importance is to realize that the dynamic stabilizers of the proximal interphalangeal joint are the flexor and the extensor tendons. As they contract isometrically, It stabilizes the proximal interphalangeal joint. Also, not to mention that the palmar lip of the base of the middle phalanx is a very, very important stabilizer of the proximal interphalangeal joint. In fact, studies by Hastings and colleagues have shown that if you cut off all the stabilizing structures, including the volar plate and the collateral ligaments, and if you keep the volar lip of the base of the middle phalanx intact, it still continues to be very stable. On the other hand, in the absence of all these stabilizing structures, if you cut the base of the middle phalanx by about more than 30%, or definitely more than 50%, then it sort of subluxes dorsally. And we'll again come back to this when we talk about the hemi-hamate arthroplasty. Now, fracture types, there are three distinct types of fractures in the base of the middle phalanx, which often are misunderstood. But it is important to make this very, very clear in this presentation. The picture on the first side, the X-ray, is a dorsal fracture subluxation. The base of the middle phalanx is subluxed dorsally, and there is a palmar lip fracture. The picture on the middle is a palmar fracture subluxation, where the base of the middle phalanx is subluxed palmarly, and there is a dorsal lip fracture. Whereas the picture on the extreme right is a combination of both, where there is a dorsal and a palmar lip fracture. And there is also a fragment in the middle which has been sort of punched into itself. And this is called a pylon fracture. Although they are all fractures of the base of the middle phalanx, they are all both mechanism of injury-wise and treatment-wise very, very dissimilar. If you look at the mechanism of injury, how does a dorsal dislocation happen without a fracture? A dorsal dislocation is usually a hyperextension injury, where the joint goes into hyperextension, and then the volar plate sort of ruptures as it's shown in the figure, and then the whole of the middle phalanx subluxes dorsally. You again have an associated collateral ligament torn on one side, the volar plate is ruptured, but the collateral ligament on the other side is usually intact, and that plays a major role in stability when the joint is reduced back. Now, how does a dorsal fracture subluxation happen? This injury happens with axial loading with the finger in a flexed position. Now, this is just rampant in cricket players. They try to catch the ball in a very close fielding position, and the ball hits them in a flexed finger position. Now, what happens is the base of the middle phalanx is driven dorsally and proximally, and the volar lip hits the head of the proximal phalanx, fracturing it. And as the force continues, it continues to go dorsally. And what makes it worse is the pull of the extensor tendon and the pull of the flexor rigitorum superficialis, which sort of adds a vector which is oriented dorsal proximal and palmar distal. Now, this makes it a very, very unstable situation. And this is something we see quite commonly in our practice. Now, the mechanism of injury of a palmar subluxation is exactly the reverse of this. This is a hyperextension force on a flexed finger, and then the dorsal lip fractures and the base of the middle phalanx subluxes palmarly. Now, the mechanism of pylon fracture is again different from all the ones which are described. This is an axial load on a straight finger, where the head of the proximal phalanx just drives itself into the base of the middle phalanx, just exploding the base of the middle phalanx, creating a dorsal lip and a palmar lip. Now, the most important criterion to call something a pylon fracture is that there's a simultaneous breakage of both the dorsal and the palmar lip, and there's also a central depressed fragment. This is a very, very important concept to understand when we treat PIP joint fracture subluxation. As I mentioned before, the palmar lip of the PIP joint, or the base of the middle phalanx, constitutes a significant stabilizing factor in PIP joint injuries and PIP joint mechanics. As I mentioned before, you cut off all the collateral ligaments and you cut off the volar plate, the joint still continues to be stable in the presence of an intact palmar lip of the base of the middle phalanx. On the other hand, when the base of the middle phalanx is fractured and the palmar lip is also fractured by more than 50%, that becomes a very, very unstable situation. So the message here is that if you look at a significant amount of palmar comminution, especially the palmar lip or the base of the middle phalanx, then you're dealing with a significant amount of instability. Now, percentage of dorsal lip is important when we talk about palmar fracture subluxations, the more the percentage of involvement, the greater is the instability. Now, when you look at the clinical examination of these patients, it's very, very important to find out the mechanism of injury. Although I do confess that they are not able to clearly tell us whether the finger is flexed or extended or whatnot. But it definitely helps to find out a little bit, probe a little bit into how the whole thing happened. Now, whether it's open or closed, this is very important, especially in dislocations, where there's usually a palmar-sided transverse laceration through which the head of the proximal phalanx is protruding out. If there are pre-existing deformities, like in some of the cases I'm going to show you, it's very important to document that. Neurovascular deficits and associated injuries will also have to be documented. Now, if there's one message in this entire talk, it's only this message. Whenever there is a single finger which is injured, it's important to take an X-ray of the injured finger, especially the lateral view, rather than the whole hand. Now, this is a clinical example where a patient had an injury in the cricket field, and you can see that the PA and the oblique are not showing much, but you can see what is happening on the lateral radiographs of the digit. So this is a very, very important message I want to convey in this talk. Please X-ray the injured digit and not the whole hand. The next is to understand what exactly a V sign means. A V sign is indicative of a dorsal subluxation. Now, if you draw a line parallel to the base of the middle phalanx and then along the head of the proximal phalanx, when the PIP joint is dorsally subluxed, and as shown in the picture, you get a V shape. Now, whenever we are treating proximal interphalangeal joint dorsal subluxations, if we keep seeing this V, then we are not done yet. The subluxation is not corrected, however good any of the other criteria might be. So we need to work a bit more on this and make that V disappear. Now, this is a concept which was introduced by my colleagues in Singapore, Andre Chia and Ruth Tan. They proposed the concept of what is called a circle of happiness. Now, basically what it meant that when they looked at some of their patients who had proximal interphalangeal joint dorsal fracture subluxation, the V sign was still persistent. Because you can accuse me of going back on what I said just now. I kept on hammering the V sign. Now I'm saying the V sign is not that important. But what it exactly means is that you could have a subtle amount of V sign, but if you have the two circles, the first circle drawn along the base of the middle phalanx, collinear with that, the second circle along the head of the proximal phalanx. And if these two circles are sitting inside each other, then you're pretty good. You're likely to have a reasonable good range of motion. That's the circle of happiness. Now, this is the classical case. You can see that in this patient, there is a V sign. But if you look at the circle of happiness, the circles seem to be quite happy fitting into each other. And that's the range of motion which the patient has. Now, coming to treatment of closed dorsal dislocation. Now, what is the aim of treatment? The aim is to get a concentric reduction, and you've got to get a stable reduction to mobilize the patient early. Now, what is the criteria for stability? Now, you call it a stable reduction when close reduction is possible. There is very, very minimal mediolateral toggle. I have to confess that I don't try and do this. And the most important thing is it does not dislocate when the PIP joint is in full extension. Of course, assuming that digital block has been given and the patient can do this without much of a discomfort. It is important to remember that this is an injury which is unstable in finger extension, which means if you keep the finger flexed, the joint is going to sit in place and further flexion is not going to endanger the corrected dislocation. Now, if you look at a clinical example, this is a patient who had an injury while playing volleyball. Now, she's one of our students and she came to us with this picture. You can see the grotesquely deformed PIP joint of the little finger. The X-ray is showing an injury to the radial collateral ligament, which is obvious. There's also a dorsal subluxation because there's no sign of a fracture. So we gave her a digital block and we reduced the whole thing. Now, once you reduce the whole thing, most often than not, it is usually stable. Now, what we do in an unstable situation, we'll talk about it a bit later, is usually stable. Once it is usually stable, all you need to do is to give them a splint on the dorsal side and encourage flexion. What you should not do is to allow them to do full extension, at which position the joint is endangered and it can jump out. As time goes by, the structures on the palmar side of the PIP joint sort of tighten up a little bit, and over time, a full extension can be allowed. But do they get full extension at all? Usually not. So what to expect? This is the same person at about 6 months post-reduction. She has a minimal discomfort. She's a dental student. She's gone back to all her professional activities. She's able to flex the finger fully, as you can see in the picture. She's got a small fixed flexion deformity about 10 degrees. Now, usually it can be anywhere from 10 to 30 degrees, depending on how young the patient is. Now, we come to dorsal PIP joint fracture subluxation. Here, there are two parts to it. One is a fracture, the other is a subluxation. The fracture is usually on the volar lip. And as I mentioned, the greater the comminution, the more the unstable component, and you also have the subluxation. Now, it is important to reduce the subluxation and hold the joint in the reduced position. Fracture stabilization is ideal, but it is not compulsory. We'll see more and more examples of this as we go on. Now, this is the commonest scenario we get. There is a dorsal fracture subluxation. The palmar lip is anywhere from 10 to 30 degrees. Now, many times we see that there is an attempt to percutaneously fix this, or many times because the finger lateral is not done, this injury is sort of missed. The simplest way to treat this fracture is to flex the finger, get the joint reduced, and then put an extension block pin. Not transfix, but put an extension block pin so that within the range of motion which is available, the finger can be mobilized. Now here the picture, the radiological picture shows the extension block pin in place. And this is the intraoperative movement. Now, most often than not, I try to do these procedures under local anesthetic because the range of motion gives me a lot of information about how much I can mobilize them postoperatively. And that's the intraoperative movement. And this is the patient at 3 months follow-up. And nothing has been done about the palmar lip fracture. And a palmar lip fracture is capable of healing by itself if the joint is in place. Now, again, this is a patient who had a dorsal fracture subluxation. You can see now what I did try in this patient is I wanted to fix the palmar fracture fragment so that the volar buttress of the base of the middle phalanx can be sort of restored. So we did a stock gun approach. We exposed the base of the middle phalanx, and then that's the defect which you can see in the picture. So we went on to fix it with two 1.5 mm screws and showing a very, very good reduction. Of course, you can shoot me in the head for this because I just now said the fracture fixation is not necessary. But of course, here, the most important point is the reduction of the subluxation, and the fixation was done to hold the subluxation in place. If it is big enough, the fragment is big enough, it's really a very, very good option to do. Now, this is the other side of the injury, which is the palmar subluxation. This is again a patient who was playing cricket. Cricket seems to be the factory of all these injuries. And this patient had an injury while playing cricket. This is actually not my patient. This is the patient of Dr. Sailesh Gupta. Sailesh, if you have keyed in, I'm sorry I didn't take your permission before doing it, but I've acknowledged you in this presentation. But thank you very much anyways. So the palmar, the base, at the dorsal base of the middle phalanx is broken, and the whole of the middle phalanx is subluxed palmarly. And that's the manipulation putting the joint in place. So this is a very, very good way of doing it. You can stabilize the whole thing with an external fixator and supplementary pins, as has been done here. And this is very, very common. You don't see a great X-ray, but as long as the reduction is concentric and the joint is in place, you get a reasonably good amount of movement. Now, to sum up, what exactly are we supposed to do in acute fracture subluxation of the PIP joint? The most important thing is that first line, reduce the subluxation. That's the most important. Reduce the subluxation. Hold the joint in reduced position. Remove the implant in 4 to 5 weeks and put the patient on supervised physio. It's not mandatory to fix the fragment dorsal or palmar, but if you can do it well, please do it well. Now, what are the problems in late presentations? As we see in most other orthopedic situations, there is tightness of periarticular tissue, which makes it very, very difficult to reduce by closed methods. CRPS is a very, very common problem, especially in the place where I live, because I can say to the fair amount of surety that 80% of these injuries are treated by the traditional bone setters who put tight bandages all over the place. Associated deformities are galore, and these come in the way of giving good results. skin wounds can be a problem, especially ones when they are treated by traditional bone setters. Now, what are the options for late presentations? You can do external fixation distraction, hemi-hamate arthroplasty, and then volar plate arthroplasty. Now, this is an example of a patient who presented to me with a cricket ball injury. 1 year after he had the injury, he had a very, very stiff finger, and that's the amount of movement you got inside the theater. Now, what did we decide to do on this? This was basically inspired by Dr. Hemant Pratankar during one of the webinars I attended. And I was surprised by the fact that he never mentioned anything about hemi-hamate arthroplasty or volar plate arthroplasty. And this was a technique he demonstrated at that time, and he showed some mind-boggling results. So I was inspired by that. So I put a distractor, a fixator on either side of the affected finger. And then if I'm able to reduce it closed, I put an extension block pin as well. This is a situation where I just put on a distractor. And post-operatively, we put the patient on palmar bar and a flexor outrigger traction. After this, they sort of develop fixed flexion deformity, which is corrected by a PIP joint extension splint later on. So after about 2 months of supervised rehab, they get almost full range of motion. Now, this is again a patient who had a similar type of injury, cricket ball injury. Again, is a very prominent actor, external fixated distraction with a pin. And then that's what he was at the end of it. The important thing to note is that the fracture sort of falls in place. So, and when the fracture falls in place, they get very, very good range of motion. Now, if you're up for something very fancy, you can do hemi-hamate arthroplasty. The basic principle is that you take a graft from the distal part of the hamate and you put it in the defect in the base of the middle phalanx. Now, why did Dr. Hill Hastings, who discovered this procedure, go to the hamate? The hamate has got a ridge in the middle, and so does the base of the middle phalanx. So that is why you spoke about the tongue in groove configuration. That ridge goes and sort of fits into the reciprocal groove in the head of the proximal phalanx. So this is a patient, is a clinical case, dorsal fracture subluxation. I put an extension block pin. Very, very nice. He was showing very, very good range of motion. So I was a bit under cautious or a bit over enthusiastic, whatever you want to call it, or a bit stupid. So I removed the pin at about 4 weeks. And then he actually came to me for a splint with an FOT. But luckily, he had also done an X-ray of his finger before he came. And I was showing him another patient's X-ray and another patient's results. And he looked at that X-ray and said, look, mine is not looking like that. And then suddenly he pulled out the X-ray from his pocket, and that's what it showed. The whole thing had re-dislocated dorsally, and there was complete comminution at the base of the middle phalanx, especially the palmar lip. So we decided to do a hemi-hamate arthroplasty. The exposure is very standard to do a volar approach with a radially based skin flap. The neurovascular bundles are protected. The flexor sheath is open between the A2 and the A4 pulleys. I'm quite generous with it. So retraction of the flexor tendon happens, and then you see the defect at the base of the middle phalanx. That defect is sort of taken down, and the defect is filled with the hamate graft. That's an incision demonstrating the hamate graft, the picture on the extreme right. And that's how it looks. So we fix the hamate graft with 2 screws. The size of the screws depends on the size of the graft and the defect. And this shows a nice reconstruction of the joint. Post-operatively, we put the pulley, which I've taken as a flap, back so that the flexor tendon doesn't sort of bowstring. And this is something you'll always see when you do a hemi-hamate graft. Although the intraoperative picture showed very, very good reconstruction, you'll always see a small step in that base of the middle phalanx. That's because of the difference in thickness of the articular cartilage between the hamate and the native base of the middle phalanx. This patient is still on rehab, so I can't show you any post-operative pictures. Now, this is again another patient who had a football injury. This is not a cricket ball injury. He came to me after 6 months, and then we did a hemi-hamate arthroplasty on him. And what happened, like most of the cases, I lost him for follow-up. And then one day I found him in Instagram. This is what he's doing. So I'm assuming, although I'm not showing you pictures of the finger, I'm assuming that if we can do this, then I think his hand is fine. You also have the option of volar plate arthroplasty, which was popularized by Richard Eaton, where the defect in the base of the middle phalanx is sort of reconstructed with the volar plate of the PIP joint. Now, the volar plate arthroplasty achieves two things. One is it acts as a volar tether, which prevents the dorsal subluxation of the middle phalanx. The second is it sort of recreates a little bit of a gliding surface there. In fact, if you read Richard Eaton's paper, he shows pictures where the base of the defect, where the volar plate actually slowly becomes fibrocartilaginous, actually reforms bone there, and the volar lip is reformed. Now, this is a patient on whom I did a volar plate arthroplasty. This patient had a cricket ball injury again, dorsal fracture subluxation of the PIP joint of the index finger, that's the defect. And then the volar plate, which is proximally based, is now taken and it is shoved into the defect, create a volar tether and a gliding surface. And that's what he was at the end of about 6 months. You can see that the joint is sort of in place. You can see that trough which was created both by the fracture and by me to shove the volar plate there. Now, we come to the last slide, which is, these are the points which I thought you should take home. The mechanism of injury, although cannot be very clearly explained by the patient, gives you clues to the type of injury. It is very, very important to differentiate between a dorsal palmar fracture subluxation and a pylon fracture. You cannot do a hemi-hamate arthroplasty in a patient who has a pylon fracture. A lateral radiograph of the finger is paramount. There's only one lesson, one take-home message in this entire presentation. The percentage of volar lip comminution indicates a degree of instability. The more the comminution, the greater the instability. The treatment aim is not to fix that fracture, but is to reduce the subluxation and hold the subluxation. It's important to prioritize what we need to do. Fracture fixation is desirable, but it's not compulsory. Now, in our scenario, we see them late. So as I showed, you can have external fixating distraction. You can do a hemi-hamate arthroplasty or a volar plate arthroplasty, whichever you are comfortable with. Thank you very much.
Thank you, Srinivasan, for such a elaborated and nice talk. And I think the most important lesson is to take lateral view of injured finger. That can prevent.
I think so. I think so.
Injury to be missed. So I would invite all the faculty for the discussion and their thoughts and questions. So to start with, that Srinivasan, what difficulties you encounter when you fix the dorsal fragment, which is covered with extensor expansion? Suppose.
Okay.
Yeah.
Okay, I have not done many of them, but whatever I have done, the first thing is not to hyperextend that joint. Because the moment we hyperextend the joint, the fragment sort of jumps off and goes off proximally. In fact, you might need a small amount of flexion of the joint so that the fragment comes and sits there. That's number one. And in that position, I transfix the joint, with a wire from the base of the middle phalanx going across the PIP joint, and I just keep it there. So I do not attempt to go and fix the fragment from the dorsal side, because sometimes if you sort of break it, then you're going to be in a lot of trouble. And as I mentioned, in all these fracture subluxations, the correction of the subluxation is either palmar or dorsal is more important than actually fixing the fracture.
Srinivasan sir, thanks for a very nice talk. My question is that would you reserve hemi-hamate arthroplasty in chronic cases for only strictly dorsal fracture subluxations, or you would also advocate it for dorsal fracture subluxations with some medial or ulnar subluxation also included with that?
See, usually it's the hemi-hamate. I've never done it for an acute situation. I usually do it for a late presentation. Now, the hemi-hamate does not address the medial lateral instability. So, but usually when you open it up, you will see the collateral ligament always intact. You will seldom see the collateral ligament torn. I think the fracture sort of protects the collateral ligament, like in many of the other joints. So I have never come across a situation where the collateral ligament was also gone and something had to be done about that. The moment you sort of open up the joint and then you put the hamate there, it's sort of reasonably okay. I've never had a medial lateral instability. If you have a medial lateral instability, then I think there's a comminution on the radial and the ulnar side of the base of the middle phalanx, which has not been addressed. It's like a tibial plateau fracture, which is depressed and the depression has not been elevated and there's a medial lateral instability. Or there was a lot more comminution and I just sort of underestimated the comminution, thought it was just a volar lip, which can be replaced by a hemi-hamate. So that's a problem.
Can I ask a question, Dr. Srinivasan?
You can, Parag.
Yeah. So if given a choice in an acute, say, subluxation of the PIP joint, less than 50% involvement, would you like to treat it in a dorsal block wire or a flexion splint?
Dorsal block wire.
Oh, always. And you do it?
As much.
Okay. But have you encountered rupture of central slip when you start the active range of movement and have some laxity?
I have not encountered central slip rupture because the central slip is quite broad there. Okay. So I've not encountered, I've been rather fortunate enough not to encounter it yet. I hope it won't happen in the future. But one problem I face there is the pin tract infection.
Yes.
And pin tract infection there is a nightmare because it just becomes a PIP joint septic arthritis.
But do your patients move in dorsal block wire up to 90 degrees?
You mean 90 degree of flexion?
Yes.
They usually are able to do because you put the wire in flexion, right? So you already given them that movement. So they're usually able to do, although I have to confess that there's still a lot of pain. They're not very comfortable doing it, but if you sort of push them, they can.
Okay. Okay. Is that the similar experience with Dr. Vinit, Dr. Amit, and other faculty also? That after dorsal block wiring, my patients are not very comfortable to move up to 90 degree.
The other thing I do is after I put the dorsal block pin, I passively sort of flex the PIP joint so that everything on the dorsal side sort of stretches out.
Okay.
And the other thing I do is I'm quite generous with the wire tract on the dorsum. In fact, I make a small incision, cut through the extensor tendon also.
Okay.
So that there's nothing coming in the way.
The point to give a small incision along the longitudinally so that the joint can move freely.
That's right.
This is what you do.
That's right.
My patients do not move it as good on an extension block, but I find that the procedure is easier than a Suzuki frame. And ultimately, in the long term, at 6 months down the line, the range that both the groups attain is the same. So
Completely
I think
agree with you.
Yeah, the early rehabilitation is easier with Suzuki frame, but then finally they get good range even on extension block pin also.
Completely agree with you.
Yeah.
I think the V sign should not be there. You should not flex the joint to reduce. You should push the middle phalanx to reduce. So if we are pushing the middle phalanx, there would be a congruence curvature of the joint. So after that, you can put the wire. But if we want to just go and flex the joint to reduce, the V sign would be there, even persist after that. So this is the difference, I think.
I always put the wire in flexion because the joint reduces only in flexion. And I'm not too much worried about the amount of flexion I'm using because that was again inspired by Dr. Patankar. I mean, who used that, he used a very, very nice word. He creates an intentional fixed flexion deformity. Now, this is a little bit of contrast from what the thought process of Dr. Hill Hastings, because he created the hemi-hamate arthroplasty because you don't want to flex the joint too much because it's eventually going to create an FFP. So it's interesting that two surgeons had diametrically opposite thoughts and produced good results. That's very interesting.
One question, Dr. Srinivasan.
Yes, Vinit.
There are three parts when there is a fracture dislocation. So the dorsal part, the dorsal 1/3 remains intact with the dorsal part. There is a small depressed middle third part, and there is a volar part that is on the volar side. So what do you think about this middle depressed part? Anything for that in acute or chronic?
Okay, in a chronic situation, I just go there thinking I'm not going to be able to fix anything. So whether there's a lip, whether there's depressed, because either way, everything is going to go to the bucket and it's going to go get a hemi-hamate or it's going to get a volar plate arthroplasty. So there's no problem in a chronic case. In an acute case, yes, of course. In fact, the patient on whom I showed that the volar lip fixation, he had a small central depression. So we had to elevate that depression and then put the volar plate back. I mean, the volar lip back and then fix it. So that was a central depression there.
I have a question, so can I ask a question?
One question,
Sure.
Dr. Srinivasan.
Yes, sir.
Fixation method, what you prefer, K-wire or screw or external fixator?
For an acute case, sir.
Yes.
For an acute case, my favorite is that K-wire, that extension block pin.
Okay, sir.
I think it's just unbelievably simple that sometimes it's even difficult to accept.
And mini screws?
Many screws are fine, sir. I don't have anything against them. But in my opinion, if you can solve the problem with something like this, then I mean, I would do that. But on the other hand, I have a low threshold to open it up. Suppose I don't get proper reduction, which happened to us very, very recently. Unfortunately, we didn't have the screw set at that time. So on that situation, we were cursing ourselves. We should have asked for a screw set. So that's where the problem happens. So my thing is we reduce the subluxation, hold it with an extension block pin. If it stays there and the patient is able to do full range of motion as in full flexion, then we just leave it there. On the other hand, in spite of the pin, it just continues to wobble. It sort of dislocates on the sides and things like that. Then that's a real problematic situation. So in these situations, we might even have to do a hemi-hamate primary or a volar plate arthroplasty because it's a really very, very unstable situation. Or an external fixator is a good idea. Reduce the subluxation, neutralize the whole thing from with fixator on sides. I think it's fantastic.
Thank you, sir.
My question to both Srinivasan sir and Parag sir. Many a times we have this central depressed fragment along with the dorsal subluxation. So would you be really particular about the reduction of the central fragment, or you feel that even a remodeled joint gives as good a result as a very well reduced joint?
So I would like to address this as honestly, in only one case, I was very confused and patient was high demanding in the form of like a Ranji player cricketer, where I got the CT scan done of the 3D CT scan done for the PIP joint. And it was my surprise that almost the central depression fragment was 30%. And in that case, I made a dorsal incision on the middle phalanx, and just like a tibial plateau, I made a small window with a small drill. And you will not believe, I just elevated that fragment, and it was of course day 4 of the injury. But in that case, I did not put the dorsal block wire. I put a static fixator in extension. And then at 3 weeks, then I started mobilization. The rest of the things, usually because PIP joint is not a load bearing joint, And honestly, arthritis is not, we don't know. Of course, theoretically, it can cause arthritis. But if possible, we should try to correct that central depression. If it is not possible, then we don't need to open it, but simple Suzuki frame or a dorsal block wire and your usual treatment should suffice. That is my opinion. And chronic, as Dr. Srinivasan said, it's anyways, we are going to do hemi-hamate, so it doesn't matter. I hope I have answered your question.
Yes, sir. Thank you. What I have seen is that if I have tried to reduce it, I have reduced it on table, but in the sequential X-rays, as the weeks pass by, I don't know what happens. It again goes back to its own place.
No, then you have to put a transverse wire from dorsal to volar. Don't, I mean, just to maintain that, depressed fragment in the same position. Yeah, you have to
we said
that wire. Yeah.
raft wires.
Yes, yes, raft wires. Yes.
The thing is, I try not to put too many wires there because of two reasons. Number one is that these fragments are on the concave side of a hinge joint. The concave side of a hinge joint is very forgiving, not the convex side. As we see in a distal radius fractures, many distal radius fractures are quite forgiving. The other thing is that when I stick wires to hold the small fragment from different sides, now the finger is not virgin on any side. It's got important soft tissue structures 360 degrees, and I always worry about impaling them and producing extensor problems and flexor problems and things like that. The key is to reduce the subluxation, hold the subluxation, and then you'll be good. In fact, in Dr. B.B. Joshi's paper, there is a patient who had close to 70% comminution of the volar lip. Now that's a lot. So he, at least according to the paper, he successfully treated them with an external fixator. So I think it again emphasizes the two important points, the subluxation, and then the concave side of the joint is capable of forgiving a bit more than the convex side. So that's what it is.
Yeah, Dr. Raghavendra, you want to ask something?
Yeah, good evening, sir. Actually, when you get a patient who has a part of the joint gone, then it becomes, the decision, what we have discussed, it becomes easy after that. But then sometimes we get patients who are like young patients, active patients who have a sort of pylon fracture where everything is comminuted and it is nicely neglected, everything is malunited or non-united, and then the patient comes with a painful job of movement and then they want their movement back. So in those situations, we cannot do a arthrodesis of some sort. So what is your experience with that? Is external fixator good in those situations, or some sort of interposition arthroplasty or something of that sort? That's my question.
Now, I try not to fuse a PIP joint, because of the simple reason that patients seldom come to me, at least, just for pain. They always want movement, as you quite rightly mentioned. So when they want movement, if you just tell them I'll fuse the joint and then you fuse the joint, they're very, very disappointed. And I would rather have them move a little bit with some pain rather than fusing the joint. So I seldom fuse the joint. I've never done this in 25 years. Point number two is that an external fixator is still a very, very good option in this. I think I really do not know how it works, because some of the examples I showed you, they all came to me after 2 months with very, very stiff joints. Especially the first case, the clinical case I showed you, that man had about 10-degree movement in the PIP joint 1 year after his injury. So I put a distractor on him and then we got full range of motion. He's now 1 year down the line. He's 37 years old. He gets up in the morning with a little bit of stiffness, but after that, he's fine. So I would still put a distractor, distract it, give it a chance, because a distractor does not burn any bridges. If at all there's something to gain.
And interposition arthroplasty or something of that sort?
I'm not a big fan of interposition arthroplasty because I think it destroys the biology quite a bit. If it destroys the biology, then the question of remodeling does not come in. And I think the body remodels itself better than the surgeon remodeling it.
Thank you, sir.
Yeah, thank you all for participation. We will continue our discussion. For that, I would invite Dr. Parag Lad from Mumbai to present his talk.
Dr. Amit, is my screen visible?
Yes, sir.
Yeah. Am I audible also, no?
Yes, you are audible.
Yeah. So right now we have understood that one of the treatment for PIP joint fracture dislocation is a Suzuki frame. And I would like to give us some insight that if we go somewhere wrong in treating Suzuki frame, we may land up in a big trouble. So I would like to present a complication of my own treated case. So the case was a 19-year-old male he presented to me 22 days post cricket ball injury to right ring finger. And he presented to me with the range of movement of 20 to 40 degrees. There was no external injury and no other injury anywhere on the hand. And of course, there was a stiffness in extension in the PIP joint. And this was the X-ray. So may I ask the faculty with, we'll start with Dr. Raghavendra, that how would you address this patient? If this is a 20-year-old injury. Any insight, Dr. Aviral, how will you treat this fracture?
Sir, so the lateral view shows that this is nearly about 10 to 20% of the articular surface involvement with a dorsal subluxation of the PIP joint. So
Okay.
if this is 22 days old, then I'll first in local anesthesia, I'll forcefully flex the joint to disengage the fragment. Then I'll apply a biplanar static external fixator, distract the joint acutely, and then put an extension block pin.
Okay. So this is one way to treat it, but I have treated it in a Suzuki frame because I followed your first two steps correctly. I gave a digital block, and under Siam, I just checked whether the joint was getting reduced in flexion, and it was getting reduced in 40 degrees of flexion. So I put the Suzuki frame. Okay. And this is my intra-op picture. Dr. Srinivasan, sir, I would like to take your opinion that do you anticipate or find out any mistake that I have done in this frame application?
Can you hear me, Parag?
Yes, I can hear you.
Okay, let me make a confession. I'm not very good with the Suzuki frame. But it looks perfect. It looks fantastic.
So will you accept this will you accept this reduction and start the range of movement?
I'll buy you an ice cream for this.
Okay. So with this image, so this was the post-op X-ray, and Dr. Amit Vyas, this was the day 4 post-op X-ray. Any warning signal in this X-ray, or you are happy with this X-ray, and can we start movement?
Yeah. It looks happy to me. Slightly over-distracted joint that may be usual for after Suzuki frame.
But do you also see this over-distraction in your cases?
Yes, this much distraction can be seen. When
okay, so
I'm also not a very good fan of this
Suzuki
frame. You can ask Vinit.
Yeah, Vinit, Dr. Vinit, do you accept this little bit distraction or any step that you would follow now?
I think, thank you for asking. This is, I think, quite right until this time. If it distracts more than that, then that is not good. But the distraction, a little bit of over distraction is fine.
Okay.
And
okay.
you can start with the mobilization. even then the patient informs you. If there is a too much pain on movement, then your distraction, you can balance the distraction by decreasing or increasing it.
Okay.
Sir,
So
Parag sir, I'd just like to ask one question at this point. Is there an upper limit to your on-table distraction that you see? Is there, because I really cannot, when I'm doing this procedure, I really cannot, if I put the rubber bands, and it is very difficult for me to really adjust the tension and again, ki itna hi hona chahiye ya utna hi hona chahiye, kind of a thing.
okay. So first of all, so this was my like 4 years back. This was my initial days. First of all, we should, according to the original article and according to one of our colleague who does maximum Suzuki frame probably in the country, I discussed with him, ideally there should be no distraction. Okay, the joint space amongst all other finger digits should be equal. That is what his opinion is. And number two is, you should apply only one single dental rubber band. That's all. You cannot apply multiple, because that, satisfaction we don't get whether we are causing enough, is this going to cause enough dynamic traction or not. So according to the article also, if you are using a dental pick rubber band, only one single. If you are using a glow rubber band, a single turn of rubber band. There should be no too much of tightness of the rubber band is recommended. So now with this post-op X-ray, it didn't alarm to me, honestly. I thought everything is fine because I was checking on the V sign and I was checking on the volar fragment. Then I asked the patient that, okay, let us move and then we will repeat your X-ray at 3 weeks. And now this is the post-operative period at 1 week, 20 to 90 degree movement. Okay, patient was doing. But at this stage, of course, the patient noticed some lengthening of the digit, as we were seeing on that X-ray, which I actually ignored. And I told the patient, you come back to me in 10 days time. Okay. Patient told me that my ring finger as compared to the left hand, is little longer. I should have kept the notice on that, but I said, okay, fine, we will keep a watch. And see, this is the shock at 3 weeks of my life. He did not come to me in 10 days. And he was, around 200 miles from my place. And I told him, okay, fine. He said that my ring finger is equal to middle finger. I said, first you get the X-ray. And he sent me this X-ray on WhatsApp. And I was you will not believe that the radiologist reported this X-ray as loss of middle phalanx. And they said your bone has been removed by the doctor and you try to reach him as early as possible. There is no bone. And this was the shock at my life. And this was happening at around 11:30 p.m. And I asked him that you show me the color of your finger. And then he said there is some numbness, but luckily the capillary feeling was good on phone. This was a video consultation at 11:30. And of course, the next step was to call him immediately. But has anybody seen this kind of ghastly looking distraction? Okay. So be careful.
It looks too much.
Yeah.
But
so,
I have seen approximately 5 millimeter of distraction, but it's too much. And usually I won't call the patient within a week. Every week we usually do, at least for 2-3 weeks, we usually do routine.
It was my last patient. If I have no close contact of a orthopedic or any hand surgeon where he's going to stay, I don't apply Suzuki frame. If he's staying in the vicinity of my clinic or hospital, I would definitely do the Suzuki frame because this is the most worrisome. So this is what my X-ray report says: a missing proximal phalanx, resorption of proximal phalanx, or osteomyelitis of proximal phalanx, and over distraction, of course. Okay. And then now, of course, the management immediate and early. Immediately, I removed the fixator. And to my, I was lucky that the finger was pink. I was worried about digital neurovascular compromise. But, because of that, so much over distraction, the collaterals were completely ruptured. And it was a completely flail digit at PIP joint. Okay. Vascularity of Allen test was, normal. And sensations of 2PD were okay. And 10 days, you see the distraction, how much distraction it has happened by looking at the, the scar of the joint. But, I told him that we will not repeat the X-ray now. Let us wait. First, you get rid of this problem and we will see. So I just give him a static finger extension splint and made him comfortable. Then on 10th day, when everything was all right, then I, called him, let us analyze your problem again. And he was again went back to, he went back to 20 to 40 degree ROM. But I was only happy the finger was, survived. So now this is the picture at, so 14th, this is the 14th day post fixator removal. And he called me and he was very happy because the bone was in place. But now I would like to have an expert opinion from the panel that how will you deal with this situation now? And then I will tell you what I have done. So there is a volar calcification of PIP joint. There is now, initially there was a dorsal subluxation and, my surgery created a palmar subluxation. So Dr. Srinivasan, to everybody in the faculty group, if you can comment how you would have treated this.
I'm going into hiding.
Yeah. But, I had no choice.
But I think this is a nightmare. I mean, it is amazing that you decided to discuss this, and I think you should publish it somewhere because I don't think the world has seen anything like this.
Yeah. So this I have published already. Yeah.
Oh, great. Okay. So I think the palmar base of the middle phalanx is basically, it's gone. I mean, I don't know whether it's the palmar base which is gone fully or it's a calcification on the palmar side.
Plate calcification. So there was a volar fragment. And, that got over distracted along with the volar plate, and the entire fragment with the volar plate got calcified, and that pulled the middle phalanx down. So,
and what is his range of motion at this point in time?
It was completely stiff. In fact, there was a now dimple on the dorsal aspect of the MP middle phalanx base, because of the joint got subluxated.
And he wants more movement, is it?
Yeah, he said, now see, my finger has survived, initially, now this is looking more crooked. So do something.
Oh my goodness. That's, PIP joint arthrodesis.
Yeah. So, I discussed with him that we go now from the volar side, excise that fragment and consider volar plate arthroplasty. Okay. And, PIP joint arthrodesis. So these are the two options that I discussed, And he said, no, doctor, arthrodesis can be done anytime. So he chose the first option. I said, okay, fine, let's, continue with the battle. And this was my pre-op range of movement assessment. So this was my pre-op active. There was no movement at all. This is the mediolateral stability. And and this much is the flexion and extension. So now we are now looking for second surgery. Like this is the joint was stable, and this is now I did the volar plate arthroplasty. After excising that fragment, I did the volar plate arthroplasty, and on table I got 20 to 95 degree movement. Then I thought I will just put a dorsal block pinning, and this is the follow-up of same patient at 4 months. This much is the flexion. He was, I was safe, 20 to 90 degree movement, completely stable finger, and length of the ring finger was definitely longer than opposite hand, but definitely smaller than middle finger. And this is the X-ray, second surgery. So this was my case. I am happy to have any criticism here.
I think you should go on a holiday.
Yeah. So the conclusion is very routinely performed procedure, but the disaster was because now if you see, I would like to just go back in my presentation, and I would like to find out my own mistakes. Like you see the number of rubbers that I have applied here, 1, 2, and 3. These are all simple, small rubber, half-inch rubbers. So because one rubber I applied, I thought how it is going to how it is going to maintain the dynamicity of the fixator. So I applied 3 rubber bands. That was my first mistake. Second is when you are seeing the first post-operative X-ray with so much of like 0.5 millimeter of distraction, this is a warning signal. You should stop distraction for 1 week. That is my, that was my second, after discussing with my Singaporean mentors and Dr. Patankar and many people like Dr. Pinal. And that is how, you should stop distraction when you are seeing the first sign of over distraction. Repeat X-rays and sometime let that dynamic fixator behave like a static fixator. Okay, so if intervene timely and accurately, we can still get a reasonable function. I am lucky to get the movement, but otherwise it was a disaster which was heading towards a probably fusion. So this is this was published in Journal of Orthopedic Case Reports, and it is freely available online. So if anybody has any problem, objection, you can take a screenshot and please read this article. Thank you so much.
Very nice.
Yeah, thank you. With officials' permission, can I stop sharing the screen or?
Yes, yes.
Yeah.
So really very nice case, and it's quite a lot of learnings are there.
Yeah.
And thank you, Parag Lad, to present this case, because usually we present our success only, and it is quite important to present your failures. So thank you, Parag. Thank you, Parag,
My
for
pleasure.
presenting and publishing.
Yeah. Thank you, sir. Thank you.
So any comment from the other faculty or any suggestions? If not, I would invite Dr. Vinit for presenting his case.
Thank you.
Yeah.
Should I start sharing the screen?
Yes, 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 please.
You see the screen?
Yeah, we can see your screen,
Yes.
but can you make slides? Yes.
So there was a PIP joint, cricket ball injury, and this 20-year boy presented at 7th day, and the X-ray pictures were like this. So, any comments? Because
Extension block pinning.
yes, that's your favorite. But I have asked the same question earlier, that there is a volar fragment and there is a central depressed fragment and there is a dorsal fragment. So anything at this stage, would you like at the time of putting the dorsal block for this central fragment, or would you like to just reduce the joint and put a block pin?
I reduce the joint and put a block pin.
Sir, I think I'll go with the Suzuki frame. Why? Because I think psychologically it just gives me a satisfaction that I'll be able to play around or do more for this central depressed fragment with the dynamic external fixate.
Because I think the central depressed fragment will need elevation if at all you're going to do something. Traction on the central depressed fragment is not going to bring it up, I think. If at all we are going to address it, then I think it's going to require some sort of a percutaneous or an open elevation. And I'd be very skeptical about it, because an open is going to disrupt a lot of things. I mean, if you're going to be confident enough to get this absolutely right, which is possible, it's not impossible to do it. If you have the wherewithal, everybody is around and every implant is around, then by all means, yes. But I think sometimes the simplicity of the extension block pin is unbelievable, that it just is compelling to do it. Sorry, I'm just playing the devil's advocate.
No, it's your experience only. So this is what we want, that the experience should come out, and there is many ways to treat the patient, but the outcome should be good. This is what everyone wants. And we are discussing the options for the same thing. And you have advised that dorsal block pinning should be done. And we always look for any malalignment at the anatomical area of injury. So I always see that this dorsal block pinning is always there, but we started to use the Suzuki frame. Earlier we used it in another shape of Suzuki, the distraction as well as the mobilization. This is what is offered by the Suzuki frame. So I think when we first saw that how to apply that, and we started using it, it was more and more easier to manage the patient in Suzuki frame. So in acute injuries, maybe at the bridge of 3 weeks or a little bit 3+ weeks, there is Suzuki frame gives more versatility to treat, and because it reduces the joint as well as a little distraction, so that the congruence is maintained, and then you can mobilize it so that your ligamentous structure around that it is also mobile, not giving the stiffness to the joint. So Dr. Parag, anything you would like to say?
Yeah, so I agree with you. I would first, after a digital block, I would assess this injury under SIAM. And honestly, my threshold, if I am getting around for more than 60 degree, if I require more than 40 or 50 degree flexion to reduce this joint, then in my opinion, it requires something more than dorsal block pinning. Because I am only worried about the flexion deformity. But last 2 years, I am again going back to the dorsal block pinning, even if I require 60 degree of flexion. But this fracture, I would like to treat it with Suzuki frame.
Patni ma'am, Dr. Amit, Dr. Raghavendra, any comments from your side?
Suzuki frame is good enough for me, sir. I would prefer a frame and mobilize the patient as early as possible. If everything gets reduced, I mean, by close means, that's what.
Dr. Amit?
Yes, same. Means I would do in acute cases the dorsal extension block pinning.
Dr. Vinit, Dr.
dorsal,
Vinit, what is the role of Joshi's fixator?
So that is a static fixator. It reduces the joint, but this is another option of treating this type of injuries. But I think if we can mobilize along with the distraction, this is something new to our field. So the Suzuki frame is more versatile in that.
Okay, thank you.
And second thing, in the middle of ring finger, it is quite cumbersome to apply the Suzuki frame.
Yes, yes.
Good for index and little finger. I think so.
You have to keep it for 6 weeks. Anything you apply, you have to keep it for at least 4, 5, 6 weeks. So it is difficult to carry that. It also stiffens the other fingers also. Party ma'am, anything you would like to?
These injuries are common only in ring and middle finger only. So
yes, it's more common in middle and ring finger. It usually is associated with mallet finger, bony mallet also. One of the cases, Dr. Rajappa said, informed that it was already having the mallet deformity. along with the PIP joint fracture injuries.
So, Vinit, you carry on for
Yes.
the next.
So what I did, this is the frame and the X-ray picture after that. Any comments from the esteemed faculty?
That wire in the center of the proximal phalanx head is fantastic.
Thank you.
It's just bang on.
Yeah, this is proper.
Looks very nice. Not over distracted. If we have to learn from Parag's case.
And there is absolutely no V sign. So this is a perfect reduction.
And of course, nothing has been done about the volar lip, which
Yeah.
is fine.
Yeah, and this is what my again notice is, there is a dorsal swelling, soft tissue swelling on the dorsal aspect of PIP joint. So there must be some components of soft tissue injury with the central slip also, probably.
Yes.
No, these are all very difficult injuries to analyze. We analyze X-rays, but this dorsal swelling I have noticed many times.
Many times.
Yeah.
Yes, right. So it is the dissipation of the energy. So it goes basically to the volar lip, but also scattered around. So other injuries, other structures are also injured.
Dr. Vinit, if I am allowed to criticize, the only thing is the distal loop of your fixators are not in one line, straight line.
Yes.
The ulnar side is little distal, and because now since I have got one complication, I am very finicky about these things also. They have to be in one line. Otherwise, there is a possibility if it gets over distracted, you will have, rupture or injury to the radial or ulnar collateral ligament of that side, probably. So we should try to have these two loops at the equal length. Do you agree?
Yes, definitely. But sometimes I do it intentionally. What I see, when you are putting the distraction at the time to reduce the joint, there is many a times there is the collateral part, the volar part, as well as the lateral side of this. You see some malalignment at that level. So this may be a mistake, but sometimes I do it to distract the other side more, and the same side, the side that is having less injury, less. So this is also there, and I have seen good outcomes after that, because there is a deviation at the time of reduction. So I put a more distraction on the side where the balancing is there. So this is the learning from many times I have applied this type, the Suzuki frame. So these are the learnings. And the other thing is for over distraction, I just don't put the rubber bands. We take this IV line set.
Yes. Yeah.
So put make the tube in half and just put the static distraction. Whenever there is, I usually do it 99% of the cases. I usually do the static distraction, and that keeps the joint in the position what I see on the day 1. Usually I see the same position at day 7, 10, 20 maybe. So that is a static distraction also, and it doesn't over distract. So this is what I learned from the case where I did the case. There was a over distraction, and approximately 5 to 6 millimeter overstretching of the joint was there.
Thanks.
Very nice. Very nice.
Follow.
Next, follow.
This is the frame.
Hmm.
And this is how we start the mobilization to block the proximal phalanx and ask the patient to actively mobilize at the PIP joint. And you can see that the patient is at 4 weeks. He was doing this mobilization without blocking. From the other hand, he was just trying to push the proximal phalanx by the thumb only, and you can see. The painless range is there. So this is what we can see. So the outcome in this is very good. So I think at 4 weeks he was doing this. At 6 weeks, I removed this the frame, and he is doing fine. So I think it's a very good outcome by Suzuki frame. Usually there is a good outcome, but sometimes there is, if we don't, I think a little bit of over dissection is good to stretch the ligaments, but there should not be any V sign after that. So these two things, and the static dissection, we can see the static dissection should be there, and you can see this the knots that I apply at the dissection side. So this doesn't give me a nightmare that is it an over dissection or something. So this is the learning at Suzuki frame from my side.
Can I ask a question, Dr. Vinit?
Yes, please.
So how frequently you repeat your X-rays post-op?
For 3 weeks at every week. If the patient is outstation, no worries for that. I inform him how to do the AP and lateral views of the X-ray, and he sends me the pictures. So it doesn't took a minute to do it. So the follow-up should not be lost.
Yeah. Okay.
And the other thing is because there is no rubber band, so there is no over distraction. There is no fear of over dissection. This within 7 days, if he gives a follow-up, so the stretching should be at its maximum.
Yeah.
So after that, I think there is no hurry in follow.
Thank you. Thank you.
Okay. Thank you, Vinit.
Thank you. Any other case if you'd like? After if we can,
Because
for patient presenting after more than 3 weeks, we have a patient who presented at 5 months after the injury.
Yes, you share.
I'm just
quickly.
I'm just sharing the page. So this is a 1-month-old injury. This is the malunited dorsal subluxation and the malunited volar fragment. Any comments, Dr. Parag, Dr. Srinivasan?
So I may not agree about malunion here. I would agree about only a dorsal subluxation. I am only worried about pseudo-arthrosis, pseudo-arthrosis or a cartilage wear and tear. So by looking at this X-ray, definitely, probably we are thinking about hemi-hamate arthroplasty in this case.
What is range of movement at this time?
Approximately 10 to 15 degrees only.
Yeah, I would still put a distractor and distract it. And it might still be possible to get very good range of motion.
Yes, Vinit. So what you did?
So I planned for hemi-hamate, and this is the exposure. And this is the intraoperative. Usually to volar plate are between volar plate arthroplasty and the hemi-hamate. I usually do this X-ray picture after the exploration, after the shotgun exposure of the joint, and I try to reduce the joint back. If there is a defect or oblique defect at the level of this and the V sign is still there. So I think this is an indication that I cannot reduce the joint. I cannot reduce the joint in flexion. So there should not be volar plate arthroplasty. So I did hemi-hamate in this. So this is how to measure the defect area, and took a hemi-hamate graft from the dorsal aspect, and then applied this with 2 mini screws of 1.3 millimeter width thickness. Your comments, please.
I think we should not be worried about the amount of flexion which is necessary. In fact, in that image intensifier picture you showed, I think it is reduced reasonably well. And I would have definitely accepted that amount of flexion, because I think that's something which Dr. Batankar illustrated very beautifully. He intentionally creates that fixed flexion deformity, get the concentric reduction. And then once the flexion from there becomes very good, which means full range of flexion from a fixed flexion deformity of almost close to 50 to 60 degrees. Then he puts the patient on a Kappener splint and straightens the joint on. And I think what he says about the Kappener splint is very, very true. It's a very, very strong splint. And it is capable of straightening that FFD quite a bit. But I think you did, the hemi-hamate is looking quite good. It's very nice.
Thank you. Anything, Dr. Amit, would you like to comment?
Yeah,
about the joint, reduction of the joint? Any parameters that?
Yeah, very.
So the defect, I think the defect should go, the congruence of the joint should come back, and your repairs of the collaterals and collateral volar plate and the collateral ligament complex. This is a box. So you have to pack the box again. So after your repair, your joint should be well reduced, and I think the flexion deformity that we want to create is not there in this, and we will see that in our follow-up.
Yeah, usually as soon as this bony block is restored by hamate graft, there is no need to repair of any ligament or volar plate. It reduces quite well.
Reduces by itself.
Do you repair
if
volar
you,
plate?
yes, volar plate I repair usually, and there is a, because we open the volar plate between the volar plate and the collaterals, so we want to repair that so that it should not go back, and also there should not be any friction on the tendons also, because FDS is just above this. So when a intact volar plate is there, the joint should not go, and also it should not hyperextend at PIP joint. If we don't repair the volar plate, it may hyperextend after even within 2 months, it go into hyperextension. So I think the repair should be back to back when you are opening up the joint, and it should be back like what you opened. So this is the screws that are placed, and you can see the closed. Now the A3 pulley is sutured underneath the tendons, so that the flexor tendon friction should not be there at the PIP joint. So this is 1.5 month follow-up. You can see there is about approximately 5 to 10 degrees of flexion deformity at the PIP joint, but almost complete flexion is there. So within 1.5 months, there is no deformity that we created or that we have to stretch out or anything else. This is the advantage of Hemi-hamate, and a full flexion range is there. And this is at 2.5 month follow-up. There is no deformity. Extension, full extension is there, and I think full flexion of the finger is there. So the video is not there, but complete flexion was there. So this is, I think, the beauty of this, that there is no flexion deformity within 2.5 months. You can see the full range is again available to this patient.
Nice, Dr. Vinit. So usually, I mean, very few patients of mine have got full extension like this. They do get it, but not at 2.5 months. They usually take little longer than, I mean, I need to apply Kapner splint after 3 months. So probably 4 or 5 months when they have their last follow-up to show us, that time I see this picture, but not at 2.5 months. But this is nice, very nice.
I think we did it at 1 month. Usually the patient comes to us for like in malunited or persistent subluxation, or must be having any massage history or any other history. Whenever there is some manipulation, whenever there is some additional injuries, and I think the severity of injury is the most important thing. The severity of injury should be considered in every case. There is no, this is what Dr. Amit has said, that usually we want to share the good cases only, but this is a good case only. So this is not the case where some other difficulties are there, but usually a good outcome is there. I think most of the patient gives good outcome. I have farmer patients, other like carpenter patients. So they all doing very well after Hemi-hamate. So, and usually there, this is a cricket player. This was only 20 years male patient. So usually cricket player patients are there, and cricket ball injuries give this type of injuries. So I have done cases in cricket players who are professional cricket players. So usually end up having good outcome.
Okay. Is Dr. Amit here?
Yeah. Vinit, can you stop sharing?
Yes, I am stopping.
So, are you able to see my screen? No.
Not yet. Dr. Amit, I need to catch.
Yeah, Parag, you can. Please.
So can I leave the meeting, please?
Yeah, please, you can.
Thank you, Dr. Srinivasan, and all the senior faculty. Yeah.
Thank you,
Bye,
Parag. Thank you.
Thank you.
Good seeing you.
Yeah, same here. Thank you.
So shortly, I will present this case. The idea of presenting this case, I will elaborate later. So as you can see, this is 4-week-old injury. Same, we have discussed a lot of cases. The patient is having this fracture dislocation PIP joint, and he had associated mallet finger. And he presented at 4 weeks duration. Then I advised surgery for him. Then another 2 weeks spent because of some insurance issue. So now it is 6 weeks. So Srinivas, can you quickly tell what will be your treatment option for PIP joint fracture dislocation?
I need a good finger lateral.
Yes.
So, do you have it?
Yeah, presently I'm not having this.
Okay, that's fine.
Yeah.
Now, again, it's the same thing. The principles are the same. You got to get the joint. It's dorsally subluxed, I think.
Mhm.
And there is a palmar lip. So now it's about 6 weeks. Is that correct?
Yes, yes, 6 weeks.
So I would still do the same thing. I would try and manipulate it under anesthesia. I'd get a little bit more flexion. If I get flexion and reduction, I'll put an extension block pin and also put a distractor, static distractor. If I do not get reduction, I will still put a distractor and distract it and hope that in about 4 or 5 weeks, the joint is loose enough for me to flex and reduce it, at which time I will put him on a flexor outrigger traction of the palmar bar. 2 weeks after that, he will be having a fixed flexion deformity there, but full flexion, hopefully. At which time I would put him on a Kapner splint and straighten him out. Keep alternating the splints so that he neither loses flexion nor extension. So that's how I would do it. On the other hand, if after removing the fixator, I still find the joint is sublux, it's not in a good position, I still, I won't throw the option of a hemi-hamate or a volar plate arthroplasty away. I still keep that option.
These options, no, if you are not able to reduce it.
Yes. At the end of 4 weeks to 5 weeks, when I distract,
Let me ask, what is your highest limit when you will try these close reductions?
Okay, I have done it. I mean, the patient I showed you is 1 year old.
Okay.
So, but I took my chances. See, at every step I told the patient that, look, we might go back on the plan. So it's not that I'm going to stick to what I started with. If in the middle it required a change of plan, I would just dump the original plan and go back to plan B.
Okay. So it's a good point. I will try to implement in my practice, but maybe I'm doing over. So I exposed it, and previously I was doing hamate for these type of cases. Then I saw there was an intra-articular gap, and but there was significant chunk was there, as you can see in the X-ray also. So what I did, I removed some bone from here and tried to restore the anatomy by putting this fragment back. So I think you
were not overdoing it. I think you were doing it and doing it well.
Okay, thanks. Okay. So any comment on this? Are people means anyone use this fragment?
I have tried to, but many times it's very soft and very sort of crumbles when you handle it. But if you can hold it and put it back as you have done so well, then I think it's a very, very good option.
Yeah, because in X-ray also it was looking quite big. So and simultaneously I corrected the mallet thing, and
so he got one and he got one. He bought one and got one free.
No, both were associated, and then it was a post-reduction X-ray, and at about 2 months, I started mobilization after a week or so. Then I was able to get about 100 degree of flexion and about 20 to 30 degree of flexion deformity. So
I think that's very good.
Yeah.
Where
just
you started
on this case, because this method I have tried in 2-3 patients only. So let us see how they work. Any comment or suggestions?
I think it's a very good method, but plan B should be volar plate arthroplasty or hemi-hamate.
Yes.
Which means the fragment, as you're putting the screw inside, crumbles and gets messed up, then there should be plan B.
Yes.
One thing I would like to say that I think that central depression we usually don't do anything in while applying Suzuki frame. So or a distraction or just dorsal block pinning. So I think we don't do anything for that central depressed fragment. So you should have left that so that the arch of your rotation of your base should be like congruent. And I think this small defect should have filled up automatically. I think the arch is now shorter. So there is a limitation maybe at 100 degree. Otherwise, you would have complete range.
Yes, I agree with your point, but I think it will improve.
Otherwise, reasonably done. I think it's very well done, but the range may be a little bit.
Yes.
Sir, actually, on seeing the pre-op X-ray, I could appreciate, I mean, maybe if I'm wrong, but then the joint was a little broadened and the concavity was lost and it was a little broadened. Same in the case where Vinit said that the central depression, or I mean, the Suzuki frame. So the joint was a little broadened. So if you leave that joint broadened, it becomes a sort of wiggly situation. So I think, I mean, you have to, close the gap. That's what I think. Otherwise, there will be space for the bone to wobble around and then it becomes a little problematic there. So that was my
Yes, your point is quite valid. So another case, idea of presenting this case that how this PIP joint sometimes behaves very funny. So this cricket ball injury, he was initially treated elsewhere. This was the initial X-ray. And probably the surgeon tried to reduce it with one wire, and you can see there are marks of external fixator, the transverse pin. And I think it is clearly visible now. And now this is the situation. Probably it again dislocated or it was not reduced initially. So now this is complex situation. He had some scar mark and there was only jog of movement, you can see. And quite 20 degree of flexion deformity. So anyone want to comment at this stage how you will manage? Srinivasan?
X-fix and distract it.
Again, okay. You will try the same method.
Yeah. Same.
So somehow
how much time since injury? This X-ray is of how much time?
it is I think it is 4 months now.
2 months.
4 months.
4 months.
Yes.
Because I also think I'll go with a distractor followed by extension block pin.
Okay. Any different opinion?
Plan B will be hemi-hamate.
Hemi-hamate.
Yeah.
I think Hemi-hamate should suffice if because you arthrolize the joint at that time, so that your adhesions and all these things went away. So after that, if you put a graft, there is a congruent joint reduction. So Hemi-hamate is the best answer.
I think 4 months Hemi-hamate will be better. So most of will be better.
Here, sir, actually, you're looking at the X-ray. The fragment is uniting, sort of. You can see that haziness there on the fracture line.
Yes,
So
yes.
if we put an external fixator and it doesn't come back and the volar lip or the concavity is not restored, then the whole idea is, I mean, the whole exercise would be futile. So I'd rather go for an hemi-hamate and reconstruct that concavity there. And then rightly said by sir that, while doing the surgery, you will just arthrize the joint and give him better movement. That's what.
Yes.
Hemi-hamate.
Yeah. So did the same. I did Hemi-hamate. Vinit, can you tell can you detect what are the problems?
The V sign is still there on the dorsal. There is a little bit incongruent. The defect is the volar defect is now gone, but
point is taken. So what problems you are expecting?
I think when there is a congruent joint, there is no problem. When there is a incongruent joint, there is always a stiffness or there is always a loss of joint motion.
Okay. So are you expecting stiffness and joint range of movements?
I also expect a flexion deformity in this because
Srinivasan?
I think this classically illustrates the problems of the hemi-hamate. Now, Dr. Hastings definitely did not anticipate this, I suppose, because he was, I think, taken up with that ridge in the base of the middle phalanx, which matched, he thought, was the ridge in the hamate, but unfortunately it did not. The other thing is the creation of the volar lip is not as easy as it is all the time. To reproduce the volar lip successfully every time is at least not been possible for me. Although there are tricks to do it, you can, slant the articular surface and things like that. But having said that, I've always found it to reproduce it all the time. And this is the situation. I think the palmar defect was about 20-30%. So you put a big hamate graft, because anything smaller than that is going to crumble your graft. So you put a big hamate graft there, and it's going to create an extra articular surface there. So in my opinion, although I also mentioned hemi-hamate, but I think this X-ray illustrates the problems of the hemi-hamate.
Yes.
The hamate and the base of the middle phalanx are not at all similar, especially with terms of the concavity and the curvature. They are not at all similar. In fact, I believe, I'm subject to criticism that the recreation of the volar lip is really the hand of God. It just happens.
Exactly.
Sometimes it does not.
Yeah. So, as you all told, but somehow I missed it intraoperatively, and later on I realized. Then somehow this patient was quite cooperative and started getting movements.
So that is again the circle of happiness.
Yeah, circle of happiness.
The V sign is not the be all and end all of it. You can have a small amount of V sign, and still, if the circle of happiness is fine, then I think it's reasonably good. There's no problem with that.
Yeah. So this was the range of movement achieved.
Fantastic. 4 circles of happiness: surgeon, patient, proximal phalanx, middle phalanx.
Exactly. And this is the last X-ray. After that, I have not taken any X-ray.
Look at the finger. It looks fantastic. That's it.
Yes. So this PIP joint is quite, sometimes it is funny and it behaves unusually. So
that is why I'm beginning to question this volar lip theory itself. Now, in this one, anybody thinks the volar lip has been restored? I don't think it has been restored. The V sign is still there. But look at that finger.
Yes.
It's amazing, isn't it? And you look at the fixator treated fingers, none of them have the articular congruity, the volar lip and all restored very well.
And
But
sometimes no, in some patients, even the joint is dislocated, nothing was done, and in spite of that, they are able to get good range of movement.
They have no pain, so that helps them, do a lot of things. The problem is when the pain is there. That's very inhibiting.
So my indication to treat this chronic injury, if they have some 20 to 60, 70 degree of range of movement, I will not touch them.
It makes sense.
Yeah, and if suppose there is gross restriction of movements, then only I touch and do the any procedure.
I think it's safe and it's sensible.
Yes, so I think we have discussed a lot, and now I will hand over to ROSA officials, Dr. Rahul Katta sir, for his expert comments.
Thank you, Amit. So it was a very nice presentation, discussion about the cases throughout the injuries of PIP joint. Dr. Srinivasan and Dr. Parag Lad has given us the words of wisdom on PIP joint injuries, and all the faculty members from the ROSA also took active participation in the case discussion. Very well points were raised. Take-home message is very sound and clear that all the PIP joint fracture dislocation should be treated in a proper manner, and anatomical reduction and achievement of a good range of movement is the key of success for these kind of injuries. So I thank you all the faculty members for the today's webinar, especially the ROSA president and the Jaipur Hand Surgery Society president, Dr. Purnima Patni, or guest faculty or local faculty or moderator from Rajasthan Orthopedic Surgeons Association. I am Secretary Dr. Rahul Katta. Thank you all for your participation in this webinar. Very soon we'll have another webinar, another masterclass in hand surgery. So for today, thank you. Good night. Bye-bye.
Thank you so much.
Thank you. Thank you.
Thank you.
Thank you. Thank you, sir. Thank you, Raghavendra.
Thank you. Bye. Good night.
Bye. Good night.